You are currently the only person in this conference.
Okay. All right, guys. Respiration. Okay. So we know that we have to breathe, right? That's not news to anybody here. But we have to understand why, right? The oxygen that makes up 20% of the air we breathe is critical for energy production. Your cells in your body make 20 times more ATP in the presence of oxygen than they do without it. So a biologist would say that we are obligate aerobes. We have to have oxygen in order to live. Okay, um, it is critical for ATP production, which is the energy that's immediately available for the cells to do work. All right. The respiratory system is also important in speech and olfaction, right? But there are four processes that are responsible, that the respiratory system is responsible for, that are critical to delivering the oxygen to the tissues that they need in order to live. Pulmonary ventilation is just the movement of the air into and out of the lungs, right? Without that, we're not going to be able to get gas exchange to take place, which is what happens in external respiration, where oxygen moves into the blood from the air that we inhale, and CO2 moves into the opposite direction, out of the blood and into the air that we exhale. We have to get rid of the carbon dioxide, because if that's allowed to accumulate in the body tissues, that'll create toxic conditions that will kill them. And then there's transport of the oxygen and the carbon dioxide in the blood, and that happens through the circulatory system. So the oxygen can only be transported effectively to our tissues in high concentration because we happen to have a molecule called hemoglobin in our red blood cells that very effectively binds oxygen in conditions that prevail at the alveoli and release oxygen at conditions that prevail in tissues that are metabolically active. Okay. Without that, we wouldn't be able to dissolve enough oxygen in our blood plasma to really crank up our energy production. The carbon dioxide, which is a waste gas, is transported primarily as bicarbonate anion in the blood plasma. And that's because in that form, it's much more water soluble than it is simply as a carbon dioxide gas. In addition, the bicarbonate in the plasma has a buffering capacity, and that helps to keep the body's pH within limits compatible with life, which is another important role of the respiratory system. And then internal respiration is what happens with the oxygen and carbon dioxide exchange that takes place between the blood and the tissues. And then cellular respiration, which I don't know if you could call it a part of the respiratory system, but it's certainly a part of the body's normal function, is the use of oxygen in order to remove energy from the chemical bonds of the fuel that the cells in our tissues take in. Okay. And without the oxygen, we wouldn't be able to do that to any extensive degree. Okay. So the major organs, and anatomically, are quite simple, right? There's the nose and the nasal cavity and paranasal sinuses, which are connected to each other. There's the pharynx and the larynx and the trach, the bronchi and the numerous bronchioles that branch off of them, and then the lungs and the alveoli, right? And then you can include the diaphragm in this as well. And so you can see the anatomy here, right? It's relatively straightforward. You can see that we've got, again, the laser pointer, we've got a nasal cavity with the conchae and the meatuses, right? The air goes in the external nares, past the conchae and the meatuses, it passes the olfactory epithelium up top, goes into nasopharynx through the posterior nares, goes through the oropharynx, laryngopharynx, and then it goes into the larynx through an opening between the vocal cords called the glottis. And then it goes down through the larynx and into the trach. And then from the trach, it's going to bifurcate at a structure called the carina into the right and left lungs at the right and left primary bronchi. And then those will branch extensively into bronchioles that will ultimately end the conducting division at the terminal bronchioles. And then the respiratory division will pick up with the respiratory bronchioles, the alveolar ducts, the alveolar sacs, and the alveoli. And the difference between the respiratory and the conducting division of the respiratory system, as we discussed earlier, is that in the respiratory division, you're doing gas exchange, right? Which is really the money end of respiration, right? The conducting division is important. It warms, humidifies, and filters the air and preps it for entry into the lungs. But if we can't do any gas exchange, then really we're kind of out of luck. The diaphragm is the main driver of breathing. Okay, it's a skeletal muscle innervated by the phrenic nerve, and it is the bottom boundary of the thoracic cavity, which has a fixed amount of gas in it. So what happens when the diaphragm changes its shape is that it changes the volume of the thoracic cavity, and that changes the pressure around the outside of the lungs, and that's what drives ventilation. Okay, as the volume of the chest cavity expands, the pressure around the outside of the lungs goes down. We create a vacuum, and we suck air into the lungs. And then as the diaphragm relaxes, the pressure outside the lungs increases, and we push air out of the lungs and into the environment. Okay. The respiratory zone is where we do the gas exchange. And the reason that we can do gas exchange in the respiratory zone is because of the presence of respiratory membrane, which is capillary endothelial cells, basal lamina, and alveolar endothelial cells. Okay. And those form a barrier so thin that it's easy for nonpolar gases to cross either into or out of the blood, depending on their concentration gradients. The conducting zone, as we talked about, is just to treat the air so that by the time it gets down into the lungs, it's not filled with particulates, it's not overly dry, its temperature is nice and warm, okay? And that keeps it from chapping and damaging the delicate lung tissue. The diaphragm and other respiratory muscles are what aid in ventilation. In relaxed breathing, the diaphragm is the only player, but in forced inspiration and expiration, there are accessory muscles that also help. Okay. Now it all starts. No. Did I hear a question?
Yes, I'm sorry to interrupt, but I thought we were going over digestion.
Oh, no, I think it's isn't it respiration? Hold on. Wait a minute. Let me double check. I think you may be right. May have jumped the gun here. Let's see. My bad. Thank you for the correction. I was hooked into what we were reviewing earlier. So hold on a second. It's still all good information. Don't forget it, right? It's important for the exam. Yeah, 23. Here we go. Zoop. And here we go. And here we go. And there we go. All right. My mistake. And it will take. Boop, boop, boop. There we go. Yeah. Yeah. It should be. There we are. Okay. All right. GI, right? GI is another solution to a problem in evolution, just like the respiratory system was. And the problem that evolution presented us is that we ended up with a more complex body plan than back when we were single-celled organisms, when we could just absorb everything through our membrane and transport wastes in the other direction. When we became multicellular, we had to have a way of getting our nutrients to the cells and tissues that were distant from where the food comes in. And that's how the digestive system developed over time. And it's anatomically not that more complicated than the respiratory system. The alimentary canal runs from the mouth to the anus, and technically is still the outside of your body. I know it's kind of weird to think about, but all your life you've been a walking donut. Your body surrounds your alimentary canal, and stuff that you eat really isn't inside your body until it passes through the lining of your digestive system. So really, your waste products are never inside your body. They're just kind of passing through the middle, right? Going through the donut hole. The purpose of the digestive system is to chemically and mechanically break down our nutrients into a form that can be loaded into the blood. Once that happens, it's in the blood, it goes from the blood to the liver, and then the liver will take those nutrients from the blood and store them for later as fat or as a molecule called glycogen. And then when our blood nutrient levels drop between meals, the liver will release those nutrients into the blood so that the cells and tissues can use them to extract energy from them, right? And it's the same idea with the cells with energy, right? We can't directly use the energy that's in the chemical bonds of our nutrients. So what we'd have to do is we have to strip the energy out of those bonds and transfer it to a molecule called ATP, okay? And that's the form of energy that is useful for doing work. The alimentary canal is just the passageway, right? It goes from the mouth to the anus, and it includes the mouth, the pharynx, esophagus, stomach, small and large intestine, rectum, and anus, okay? But there are accessory organs that help the process. Teeth, tongue, gallbladder, liver, pancreas, salivary glands, okay, all help this to happen. And the system is here, and it's not that complicated anatomically, right? Again, just like in the respiratory system, we start up top, right? Except instead of the nasal cavity, we start in the oral cavity. The hard palate separates the nasal cavity from the oral cavity, and this is where mechanical and chemical digestion begin. The teeth, the tongue, the hard and soft palate, and the muscles that surround the oral cavity are going to aid in mechanically breaking the food down, macerating it, okay? And then the salivary glands are going to moisten the food, and they also contain enzymes and antibodies, as well as antimicrobials, that are going to help to chemically break down some of the nutrients, but also to begin the process of getting rid of pathogens that can produce disease that we ingest when we eat our food. Our food is not sterile, right? So there's going to be stuff on it and in it and around it that we're going to ingest, okay? Salivary glands include the sublinguals, the submandibulars, and the parotids, right? And then we swallow, and the food goes past the hard and the soft palate and the uvula, and the uvula and the hard palate help to close off the nasal from the oral cavity, right? So we don't choke when we eat. And it's going to go through the oral cavity into the oral pharynx, into the laryngeal pharynx, but then instead of like air going in the larynx, right, it's going to go down the esophagus through what's called the upper esophageal sphincter. Skeletal muscle in the top third will produce waves of muscle contraction that'll push the wet food ball called a bolus down to the middle third of the pharynx, or middle third of the esophagus, which is a combination of skeletal and smooth muscle, and then down into the lower third, which is all smooth. And then eventually that food is going to be pushed through the doorway into the stomach, which is called the cardiac sphincter or lower esophageal sphincter. And that will then close behind the bolus, and in the stomach, secretions such as mucus, hydrochloric acid, and pepsin will further the digestive process. So the mucus protects the stomach from its own acid, so it doesn't eat a hole in itself as quickly, right? The acid is twofold, right? It helps to destroy a lot of pathogens because it's a highly corrosive secretion, but it also creates an environment in which the enzyme pepsin can begin the process of protein breakdown. So that's important because the breakdown of a lot of the polymers that make up the nutrients that we eat is in digestion a stepwise process. The food will liquefy in the stomach into something called chyme, and then it'll move from the fundus to the body to the pylorus of the stomach through the pyloric sphincter, which is the doorway out. And as the stomach squirts this liquid into the first part of the small intestine called the duodenum, the gallbladder will squeeze and the pancreas will secrete material into the duodenum that will further the process of digestion. The bile in the gallbladder will help to emulsify fat. That makes it easier for enzymes that break down fat to do their work. And the pancreas will secrete bicarbonate to neutralize stomach acid and enzymes that will break down starch and protein and also fat. Okay, so that swirls around and mixes in the duodenum and furthers the process of digestion. We move from there to the jejunum, where enzymes embedded in the lining of the small intestine complete the process of nutrient breakdown. And then by the time we get to the end of the ileum, we have removed all the nutrients that we need, and all we have are waste products that are going to pass through something called the ileocecal valve into the cecum, from the cecum to the ascending colon, to the transverse colon, to the descending, and then to the sigmoid colon, and then out the rectum and the anus. Okay. On the way through the colon, the fecal material will surrender a lot of its liquid back into the bloodstream, and the bacteria that live off of our fecal material will produce byproducts that we need, such as vitamin B and vitamin B complex vitamins and vitamin K. Okay, we'll absorb those into the bloodstream through the large intestine. The nutrient absorption, remember, is primarily in the small intestine. A few things do get absorbed in the stomach, such as alcohol and iron and B12, okay? But the rest of it is going to be primarily small intestine action. And then we're going to eliminate the material through the rectum and the anus, okay? The movement from the bottom third of the esophagus on through the rectum and the anus, that's all smooth muscle control, okay? And that actually is under the control of something called the enteric nervous system, which is a nerve net that's embedded in the lining of the alimentary canal. And the enteric nervous system, in turn, is governed by the autonomic nervous system, okay? So the activities in the digestive system are here, right? Ingestion, which is taking the food in, propulsion, which is pushing it, mechanical breakdown, which is basically tearing it up, digestion, which is the chemical breakdown of the mechanical breakdown products, absorption, which is getting the goodies into the blood, and then defecation, which is the removal of the waste products. And you can see the entire process here. Now, an important point is that if we don't break down our nutrients into their smallest component parts, we can't load that material into the blood and we don't get any benefit from it. So for proteins, the smallest component that we can load into the blood is the amino acids, okay? For complex carbohydrates, it's the simple sugars. And then for our fats, it's the fatty acids and the glycerol, all right? It's only in those forms that the nutrients can pass through the lining of the digestive system. And in the case of the simple sugars and the amino acids, pass into the bloodstream and then from there to the liver. In the case of any of the lipids, pass into the lymphatic system and then into the cisterna chyli, and then from there to the thoracic duct, and then from there to the left subclavian vein. And then from there, we'll eventually find our way to the liver and the other tissues in the body. Okay, so it's sort of a roundabout route that we take. And then we eliminate the solid waste. You can see here that peristalsis is a combination of muscle contractions that squeeze the pipe, but also shorten the pipe, and that helps to push the food forward, kind of like the way you'd roll up the last bit of toothpaste out of an almost empty toothpaste tube. And then there are periodic strictures in the pipe that act to improve the mixing of the nutrients with the secretions of the digestive system, and that process is called segmentation. There are reflexes that govern when and where all of this stuff happens, right? Mechano and chemoreceptors respond to stretch, changes in osmolarity, pH, and the presence of substrates and end products of digestion that initiate reflexes that are going to activate or inhibit digestive glands and stimulate smooth muscle to mix and move the contents that are in the lumen. Okay, so the watchword here with control of digestion is that we stimulate processes ahead of where we're going and we inhibit processes behind where we've been. Okay, and that means that we don't waste time and resources doing something that's not going to help us, and we also prepare for the arrival of material so that we're able to process it when it gets there. The intrinsic and extrinsic controls include short reflexes, in which the enteric nerve plexus responds to stimuli in the GI tract. Long reflexes respond to stimuli inside or outside the tract and can involve central nervous system centers as well as autonomic nerves. And then there's hormones from cells in the stomach and small intestine that stimulate target cells in the same or different organs to either secrete or contract. Okay, so you got all kinds of things going on here. You got nerve input, you got hormone input, and you've also got these physical reflexes, okay, that are going to act to control what's happening in the digestive system and when. It's kind of interesting to think that you could cut all the nerve leads to the digestive system and you could still eat and process your food and make your waste products. Okay, so it's kind of like the heart, right? You could cut all the nerve leads to the heart and the heart would still beat. Okay? The digestive system is suspended from the body cavity by membranes that surround the upper and lower digestive system. In the thoracic cavity, that's going to be adventitia that surrounds the esophagus that runs behind the trach, carina, and the bronchi. But once we pass through the diaphragm, we have the peritoneum, right? The parietal peritoneum lines the abdominal pelvic cavity, and the visceral peritoneum is actually going to cling to the alimentary canal and the accessory organs for the most part. Okay, there are going to be some parts of the canal that are behind the peritoneum. They're called retroperitoneal. Okay, and then some that are entirely enclosed front and back within the peritoneum, and they're called intraperitoneal. Okay, so the purpose again of this is really twofold, right? The peritoneum generates a lubricating fluid that lets the organ system move without irritation, inflammation, and scarring, which is important so we don't damage the organ. But it also helps to suspend the digestive system within the abdominal, pelvic, and the thoracic cavities so that it doesn't twist, buckle, or kink, as well as serving as a route for nerves, blood vessels, and lymphatics to go in and out of the GI tract, as well as serving the accessory organs. Okay, so a lot of stuff going on here that's beneficial. Okay, some organs are going to end up becoming retroperitoneal. In the GI, that's going to include portions of the pancreas and the duodenum. Okay, in the urinary system, that's going to include the kidneys and a lot of the ureters. Okay, but the remainder is going to be intraperitoneal. The mesentery is simply a double layer of peritoneum that serves as this route for the lymphatics, nerves, and blood vessels, but it also holds a lot of body fat in it, and that serves as padding and protection and insulation, but it also serves as a fuel storage depot in the body. Okay, so we have a combination of locations here. Sometimes, if we break containment between the alimentary canal and the abdominal pelvic cavity, we run the risk of severe infection and inflammation of the peritoneum known as peritonitis. This might happen, for instance, in a ruptured appendix, or if somebody has a condition in which they have a functional or a structural block in the pipe where the food only gets to a certain point and it stops, and the pipe swells up and it can potentially blow. Okay, and the danger, of course, is that the lining of the abdominal pelvic cavity is not set up for dealing with massive amounts of pathogen, whereas the alimentary canal is. The alimentary canal is lined with a mucous membrane, and the mucus helps to flush and trap the pathogens, right? Whereas the abdominal pelvic cavity is lined with a serous membrane and doesn't have nearly the capability to deal with pathogens that a mucous membrane does. So, examples of when this can happen, right? Appendicitis, ruptured appendix, perforating ulcers, which are penetrating wounds that you can get in the stomach or the small intestine, for instance, in which we get a hole in the pipe. Okay. And what do we do if this happens? Well, we get rid of the debris, obviously. We close the hole, and then we have to give you massive amounts of antibiotics to try and fight the infection. If you don't do something about it relatively quickly, you could die. I actually know somebody that died of a ruptured appendix because he thought it was simply gastroenteritis. Okay. The diagnostic, by the way, for appendicitis is severe sharp pain at McBurney's point, which is midway between the crest of the right ilium and your navel, right? If you poke yourself there and you scream, you may have appendicitis, and you should probably go to the emergency room. Now, there are branches of the aorta that talk to the digestive organs. The hepatic artery is going to talk to the liver, the splenic artery to the spleen, and the left gastric is going to talk to the stomach. And then there's superior and inferior mesenterics. The inferior mesenteric is going to supply blood to the descending and sigmoid colon, the rectum, and the anus. And the superior mesenteric is going to supply blood to everything above that up to the stomach. Okay. The hepatic portal circulation is, as we talked about earlier, a way to deliver blood to the liver from the digestive system so that it can take the nutrients out of the blood and store it for later, as well as treat the blood that comes into it by detoxifying it and removing pathogens and adding things like plasma proteins. So the liver is absolutely critical to our survival. If we lose our liver, we lose our life. That's why the first 4 letters in the word liver spell live. That's not a coincidence. You can see in the alimentary canal a set of tissues that act together to do something that a single tissue can't, and that's the definition of an organ, right? So we have a mucosa, a submucosa, muscularis externa, and a serosa or adventitia, depending on where we are in the pipe. Okay, the mucosa is made up of epithelia lining the lumen, and then beneath that connective tissue, lamina propria, and then some smooth muscle called muscularis mucosa. And then beneath the mucosa is the submucosa, which is primarily going to be connective tissue, nerve endings, and blood vessels, as well as immune cells, large numbers of them, okay, patrol the submucosa as well as the mucosa. And then superficial to the submucosa is the muscularis externa, which is going to have an inner circular and outer longitudinal layer, and that's going to aid in peristalsis. And then you've got with the serosa epithelium and then connective tissue, right? And that serves to lubricate the organ and latch it in place so it doesn't twist, buckle, or kink. And then you can see between the layers of tissue, you've got a blood and a nerve supply as well. Okay? So the mucosa lines the lumen, right? Secretes mucus as well as producing digestive enzymes and hormones, and it absorbs the products of digestion and has an extensive surface area particularly in the small intestine. It protects against infection because it contains something called mucosa-associated lymphatic tissue, which are collections of lymphocytes and macrophages that patrol this region, trying to trap pathogens before they get into the blood. The three layers of the mucosa are the epithelial layer, the lamina propria, and the most superficial layer, the muscularis mucosa. The epithelia is simple columnar and mucus secreting, as well as lined with microvilli in most of the tract. Okay, the mucus is going to lubricate the material that moves through the tract, but it's also going to trap and flush out pathogens. Okay, and there's also going to be some enzyme and hormone secretion in different parts of the tract. For instance, there are brush border enzymes in the small intestine that finish the process of breaking down things like disaccharides and oligopeptides. Okay, there are hormones that are produced in the digestive tract that are going to coordinate the action of the stomach and the action of the pancreas and the gallbladder. Okay, so all of that is critical to normal function. The lamina propria is areolar connective tissue that contain capillaries and nerve endings, as well as lymphoid follicles that are part of the mucosa-associated lymphatic tissue that are basically macrophages and lymphocytes that defend against the microbes getting into the blood. The muscularis mucosa produces undulating movements of the mucosa that aid in mixing and absorption. Okay, so you could think of it as like wiggling the tissue that lines the lumen. Okay, the submucosa is areolar connective tissue with blood and lymphatic vessels, as well as lymphoid follicles, and there's a nerve plexus in there. Okay, the externa is responsible for pushing the food through the pipe. All right, and that's got an inner circular and outer longitudinal layer in most of the digestive tract, with some regions known as sphincters controlling the movement of food from places like the stomach to the small intestine and from the esophagus to the stomach and so on. Okay, the myenteric nerve plexus between the two muscle layers is part of the control mechanism that tells it when to contract. Okay, and again, it would operate even without any autonomic nerve leads to it. The serosa is visceral peritoneum that clings to the tract. It's areolar connective tissue covered with mesothelium in most organs, but it is adventitia in places like the esophagus. There are retroperitoneal organs that have both an adventitia and a serosa around them. Okay, for instance, the ureters and the kidneys, as well as the pancreas. You can see again the pipe and note the different tissues and how they cooperate, right? There's no one tissue that can do all these jobs together, right? There's no one tissue that would be capable of propulsion, secretion, protection, right? No single tissue could do all that, right? So you have to have an organ set up in order for that to happen. The enteric nervous system is actually where most of the neurons in the body are located. Okay, that's sort of surprising. You might think it would be the central nervous system, but it is the enteric. It's the major nerve supply to the GI tract, and it controls motility, so it basically acts on smooth muscle as well as glands that are in the mucosa, and this is what helps to move the material through the pipe. The enteric nervous system does have a connection to the autonomic nervous system. Okay, there are parasympathetic and sympathetic fibers that are going to provide suggestions to the enteric nervous system as to when and where to act, right? Sympathetic impulse is going to inhibit GI, and parasympathetic is going to promote it. Digestion is supposed to begin in the mouth, right? So the oral cavity has the hard and soft palate and uvula on top, and the tongue on the floor, okay? And it's bounded by the lips, the cheeks, and lined with stratified squamous epithelium, because this is an area that undergoes significant mechanical stress and strain. Your lips and your cheeks are controlled by the orbicularis oris and the buccinator. The vestibule is simply the recess between the cheek and the gum, which we call the gingiva. This is where people used to put snuff, right, which is a tobacco product that would absorb into the blood vessels in the gum and in the cheek and the lips. And so you get a nicotine buzz from that without having to smoke. But of course, it contributes to oral cancer. And then the oral cavity proper is within the teeth and gums. The labial frenulum is a median attachment of each lip to the gum. You can see the labial frenulum here and here. And the lingual frenulum attaches the tongue to the floor of the oral cavity so you don't swallow it in your sleep and choke to death. Okay. The hard palate is made up of the palatine bone in the back third and the palatine process of the maxilla in the front 2/3. Behind the hard palate is the soft palate, which terminates in the uvula. And the purpose of the soft palate is so that when you swallow, it closes off the nasal cavity and the paranasal sinuses to food and drink. Your tongue is mucus covered skeletal muscle, okay? And it is on its dorsal surface populated with papillae. Those are the rough peg-like projections that you feel when you rub the surface of your tongue against your upper lip, okay? And that provides friction and grip. It also helps to manipulate food in our mouth and aids in speech, okay? And helps to form the food bolus. Extrinsic muscles change the tongue's position, and intrinsic muscles will change the shape of the tongue, okay? The papillae include the valate papillae, the foliate fungiform, and filiform papillae, which are found peppered throughout here, okay? And on the lateral margins of all but the filiform papillae are taste buds, and they provide our sense of flavor, okay? The other papillae are named for their shape. Fungiform is shaped like a toadstool, filiform like a filament, foliate like leaves, and valate gets the name because of the arrangement in a V at the back of the tongue, okay? Those are the different papillae, and those are the locations of the taste buds, okay? The tongue is also near the salivary glands, right? The salivary glands include the parotids in front of each external ear, the sublinguals under the tongue, and the submandibulars under the mandible. And in the salivary secretions are enzymes such as salivary amylase and lingual lipase. Salivary amylase helps to break down starch, and lingual lipase helps to break down triglycerides. The terminal sulcus is the division between the body and the root of the tongue. The body is the anterior 2/3 in the oral cavity, and the root is the posterior third in the oropharynx, just behind the valate papillae. And then you can see here the salivary glands, right? There's the parotids, the submandibulars, and the sublinguals, right? And they're all exocrine glands that drain into the oral cavity, okay? The sublingual creates a mucus saliva, and the submandibulars and the parotids create a more serous saliva. The serous saliva has more digested enzymes in it. The mucus saliva is more in tune with lubrication and with protection against pathogens. Okay? So you can see where they drain, and you can see here a micrograph what they look like under the microscope after they've been stained. All right. What does saliva do? Well, several things, right? It retards pathogen growth because it contains antibody, has IgA in it, IgA antibody. It has antimicrobials in it, such as lysozyme. It also lubricates the food, and it also contains enzymes that begin the breakdown of nutrients, such as starch and fat. Okay? The parotid gland is anterior to the ear and external to the masseter, and its duct opens in a vestibule near the second upper molar. Sometimes we can get a viral infection called mumps, which is an inflammation of the parotids that's very painful. Most of y'all have probably never had mumps because we now have a vaccine for it. In the old days, you would simply get mumps when you were younger, and then you would get what's called natural active immunity, okay? And then you wouldn't get the mumps again in most cases. The submandibular is medial to the body of the mandible, and the ducts open at the base of the lingual frenulum, and the sublingual is anterior to the submandibular under the tongue and opens through ducts on the floor of the mouth. The different types of cells include serous cells that generate a watery enzymatic secretion, and then the mucus cells that produce the mucus. Parotids and submandibulars generate serous secretions, and the sublingual is mostly a mucus secretion. What's in saliva? Well, we kind of talked about that already. You've got electrolytes, you've got a lot of water, you've got enzymes like amylase and lipase, mucin, and then you have wastes such as urea and uric acid, okay, and antimicrobials and antibodies, okay. So this protects against microorganisms. You make about 1.5 liters a day, and you swallow most of it. Keeps the mouth moist, cuts down on cavity production, okay. The extrinsic salivary glands are activated by parasympathetic input when ingested food hits chemoreceptors and mechanoreceptors in the mouth. Salivatory nuclei in the brainstem send impulses along parasympathetic fibers in cranial nerves 7 and 9. Okay, so that's the glossopharyngeal and the facial nerves. Strong sympathetic stimulation is going to inhibit salivation and result in a condition known as xerostomia, which is dry mouth. Okay, so this is why when you freak out, right, like you have to talk in front of a large audience, you get cotton mouth. Okay, now your teeth. I love your teeth. Your teeth are awesome. Your teeth are the tools that tell you what you should eat. Okay, and we have 2 sets of teeth, right? We have our deciduous teeth. You get 20 of those, and they fall out over time and are replaced by our permanent teeth. Okay, you get 32 of those. All right. The permanent teeth come in different forms. You have incisors in the front, you have canines lateral to that, and then you have premolars and molars in the back. Okay, and that is the dentition of something known as an omnivore, right? The incisors are for chopping, canines are for slashing, and the molars are for grinding. Okay, if you look at the skulls of different animals, okay, so let's take a little sidebar here for just a minute. You'll see different dentition, right? For instance, if we were to look at dentition of a dog, right there. So let's look at a German Shepherd, right? You'll notice, right? Lots of canines, a few little tiny incisors, and just a few molars, not very many, right? And a huge ridge across the top of the skull. This is the dentition of a carnivore, okay? This is an animal that's supposed to eat raw meat, okay? So we don't do our dogs any favors when we feed them kibble, which is largely cereal, because then that causes them to get something that wolves and foxes don't get in the wild, which are cavities, okay? And then you have to take them to the vet, and you have to knock them out, and you have to get them fix their cavity, and it's a big pain, okay? They're supposed to eat raw meat and eggs, okay? They're jaw is very massive, right? And the temporalis and the masseter run all the way up to this ridge on the top of their head called the nuchal crest. So if you watch a dog or a cat eat and you look at the top of their head, you'll see the muscles working. Those are their jaw muscles all the way up there. And that's why they can do stuff like bite through bone, which is pretty impressive if you ask me. Okay. Um, the other end of this, right, is the dentition of a herbivore, right? So let's look at that. And cattle. Right? There's our herbivore, right? Now, what do you notice about the herbivore? You got incisors and molars, and you don't have any canines, right? What's the herbivore supposed to eat? Plant material all the time, okay? They have a longer digestive system. They have 4 stomachs instead of 1, like we do, okay? They have incisors and molars because they're supposed to eat grass and grain exclusively in their diet, okay? And if we feed them other stuff, then we get into trouble, okay? For instance, in countries that practice animal husbandry outside the U.S., they sometimes augment the feed with bone meal, right? And the bone meal contains nerve tissue, and in the nerve tissue is the agent of mad cow disease known as the prion, right? And so every case of mad cow that has been inside the U.S. has come from meat outside the U.S., okay? And so this is a huge problem, okay? This is also why we have a problem with mad deer disease, right? We don't have deer hunting to the extent we used to, and the deer have moved into suburban areas and have populated our cities and our suburbs, and they begin eating stuff other than plant material, which includes stuff on the ground, which includes things that have died, and there's nerve tissue in that, and they end up with a condition called mad deer. Okay, and so you'll see deer occasionally with this condition doing things like jumping off highway overpasses into oncoming cars and walking through plate glass windows in the middle of downtown Cincinnati. Okay, the fix for this, of course, is to hunt and cut down on the deer population. Right, so just a little sidebar there. I find that very interesting. If we look at the different tooth types, right, we see the incisors, right? Chisel shape for cutting, canines for slashing, those are your fangs, right? And your premolars and your molars for the grinding, right? The dental formula indicates your primary and your permanent dentition, right? You're going to have 20 deciduous teeth. Deciduous just means they fall out. And that includes 2 incisors, 1 canine, and 2 molars for the upper, and then the same for the lower jaw. And then your permanent teeth, you get 2 incisors, 1 canine, 2 premolars, and 3 molars for the lower. Okay. And for those that are curious about the molars, you got 3 of them normally. Your third molar is known as your wisdom tooth, and it comes in by the time you're supposed to have some wisdom. Between the ages of 17 and 25, they will erupt from the gum, and oftentimes they won't come in vertically. They can come in at a tilt, and that means that you're going to crush or crimp the teeth that are in front of them, and that can result in misalignment and a condition known as malocclusion. Okay, so what we do typically, if that's going to be the case, is that we extract them. Okay, we knock you out, we slice the gums, and then we pull the third molars out with the dental equivalent of a pair of pliers. Okay, that's one of the reasons why you're supposed to be knocked out for this, and that when you wake up, they generally give you Percocet for the pain, and they recommend ice and compression for the swelling. Okay, the reason that we have third molars, if there's such a pain a lot of the time, is because our oral cavity used to be much bigger than it is now. And that was back when we had a diet that was a lot more gristle and fiber than it is now. And so we needed the extra grinding capacity. But our oral capacity shrank when we discovered cooking, and our teeth haven't quite caught up to that yet. The tooth structure is shown here, right? So you can see that we have a crown, a neck, and we also have a root, right? The crown is above the gum line and covered in enamel. Deep to that is the dentin, which is much softer. Okay. At the boundary between the gum line and the neck, right, which is called the gingival sulcus, right? Once we get to the neck and the root, we don't have enamel anymore. We have cementum beneath that dentin. And then deep to that, of course, the root canal and the pulp cavity, which have nerves and blood vessels in them. Okay. And so if you end up with a penetrating cavity that gets all the way to the root canal or to the pulp cavity, then we usually have to extract the tooth. Okay. One of the things that people sometimes neglect to do is floss when they brush, and bacteria can grow in the crevice between the crown and the gingival sulcus, and that causes the gums to recede, and the bacteria can go up and under and into the pulp cavity, and that's big time trouble, because if it gets there, then you have to pull your teeth, because if the bacteria get into the blood, then you're talking potential for serious disease. Okay. So you need to brush and floss in order to avoid those things. Canine incisor and premolar are single root. The first two upper molars are 3. The first two lowers are 2. And the third and molar roots may have a single fused root, but they vary widely. Now, sometimes, if you don't do proper dental hygiene, you end up with a condition called caries, which is a fancy term for cavity, right? The bacteria that live in your mouth feed off the food that stays there after you swallow, and they generate a biofilm on the enamel of the tooth that contains different types of bacteria. They produce acids that dissolve the enamel and the calcium salts, and eventually can penetrate and soften the tooth, and can even, in extreme cases, get all the way to the root canal or the pulp cavity, right? We don't want that to happen. So what do? We brush and we floss to cut down on that. In the event that we don't have good dental hygiene, we can cause the bacteria to grow in the gingival sulcus, and that causes the gums to inflame, and that's a condition called gingivitis. If your gums bleed when you floss, you've got gingivitis. Okay. And then if we don't do anything about that, the gums will recede, and that's called periodontal disease. And what will happen then is that the connections between the tooth and the alveoli in the mandible and the masseter, where they're attached, will get loose, and the teeth will either fall out or have to be pulled out. Okay. If you end up at the point of periodontal disease, generally what they have to do is scrape your gums, pull your teeth, and then you get your third set of teeth, which you know better as your dentures. Okay. Periodontitis, that's neglected gingivitis, okay, periodontal disease, tooth loss. It can promote atherosclerosis and clot formation in coronary and cerebral arteries. Risk factors: smoking, diabetes, oral piercings, and of course, poor dental hygiene. Okay. So with that, let's bump into B. Take a look. All right. Okay. All right. Off about there. Bifurcate this guy. With it. All right. So, continuing on. Following the path of food, after we go through the oral cavity, we're going to go into the oropharynx and laryngopharynx. Share food fluid and air. Right? Stratified squamous epithelia lines these because they're under mechanical stress and strain. Okay, and there are mucus-producing glands that lubricate the surface just as they do in the mouth. Right? Skeletal muscle layers include an inner longitudinal and outer pharyngeal constrictors. Okay, so this is again under conscious control. In the esophagus, what we have is a tube that runs from the laryngopharynx all the way to the cardiac sphincter, which is the opening into the stomach. All right, and it runs through the diaphragm at an area called the esophageal hiatus, which is actually a weak spot in the diaphragm, and sometimes the stomach can actually pop through that hole and produce something called a hiatal hernia, and that usually leads to heartburn and emesis, which is throwing up. Okay, and its risk factors include obesity and pregnancy and old age. The gastroesophageal or cardiac sphincter, okay, sometimes called the lower esophageal sphincter, surrounds the opening into the stomach and controls the passage of food into it and keeping the food into it. If you have a weak cardiac sphincter, you can suffer from a condition known as gastroesophageal reflux disease, in which while the stomach is churning and mixing, the fluid in the stomach flips back up into the esophagus and can inflame and irritate and erode it. Okay, you can see the same tissues in the esophagus as you see in the rest of the alimentary canal. Right, the esophageal mucosa is stratified squamous epithelium that changes to simple columnar when we get to the stomach. Esophageal glands in the submucosa generate mucus and lubricate the bolus on its way down. And the muscularis externa is skeletal muscle in the top, skeletal and smooth in the middle, and all smooth in the bottom third. And it's surrounded by an adventitia instead of a serosa on the outside. And there's no absorption that happens here. Okay? No absorption in the oral cavity, in the pharynx, and in the esophagus, unless you're talking about something that's lipid soluble, okay? In which case it can absorb anywhere it likes. We've talked about heartburn, right? The problem is a weak esophageal sphincter. You get the acid refluxing into the esophagus, and that erodes, inflames, and irritates it, and can carve a hole in it, right? And that's very dangerous because that can lead to infection. Sometimes if the diaphragm gets too much pressure under it, you can push the fundus of the stomach through the hiatus, and we call that a hiatal hernia, and that can result in emesis and heartburn, right? It can lead to esophagitis, esophageal ulcers, and esophageal cancer, right? Because the esophagus is not set up to deal with stomach acid. Only the stomach is, for a variety of reasons we'll get into. So ingestion, right? In the mouth, we have mechanical and chemical digestion, right? We have chewing, we have manipulation with the tongue, and then grinding with the teeth, and chopping and slashing with the teeth. And then we also have the action of the amylase and the lipase, right? And that's chemical breakdown, okay? Propulsion out of there is deglutition or swallowing, right? So what happens at that point is that we push the food bolus back and into the pharynx, okay? Now, there are stages to swallowing. Let's see here. I'm going to hit that here. So we're going to hit it two places. Right. Okay. Okay. In mastication, cheeks and the closed lips hold food between the teeth, and the tongue mixes the food with the saliva and compresses it into a bolus. The teeth will cut and grind. And this is a partly voluntary and partly reflexive action. Okay, mostly voluntary. Stretch reflexes act here. Pressure receptors in the cheeks, the gums, and the tongue also act here. Okay, so let's see. Let's talk a little bit about the act of swallowing. Pause this. Jump over to it. So, brush.
Swallowing, or deglutition, is the process by which food passes from the mouth to the stomach. This movement is controlled by the nervous system and involves both voluntary and involuntary muscle contractions. Before food is swallowed, it is mechanically broken down in the mouth by chewing or mastication. The salivary glands secrete the enzymes lingual lipase and salivary amylase. Salivary amylase begins the chemical breakdown of starch, carbohydrates, in the mouth. The water content of saliva helps bind particles together to form a bolus that can be swallowed. Swallowing occurs in 3 stages. The first is a voluntary phase called the buccal or oral transit phase. Here the tongue moves upwards and backwards against the hard and soft palate to push the bolus into the oropharynx. Next is the pharyngeal stage, in which involuntary movements push the bolus through the pharynx and into the esophagus. Movement of the bolus stimulates receptors in the oropharynx, which send impulses to the deglutition center in the medulla oblongata and the lower pons of the brainstem. The brain signals the soft palate and uvula to close off the nasopharynx, and the epiglottis to seal off the larynx. This prevents the bolus from entering the respiratory tract. The upper esophageal sphincter relaxes to allow the bolus to move into the esophagus and contracts to reduce backflow into the pharynx. In the final esophageal stage, the bolus is pushed onward by peristalsis, a progression of involuntary wave-like contractions of the circular and longitudinal smooth muscles of the esophagus. As the bolus approaches the end of the esophagus, the lower esophageal sphincter relaxes and the bolus moves into the stomach. So, in summary, food moves from the mouth, through the oropharynx and esophagus, and then into the stomach. Swallowing, or deglutition, is the process by which food passes from the mouth to the stomach.
Okay. So this whole process is going to involve the tongue, the soft palate, the pharynx, esophagus, and requires 22 muscle groups. In the buccal phase, we have voluntary contraction of the tongue. In the pharyngeoesophageal phase, we have primarily involuntary vagal nerve stimulation. And then we have control center in the medulla and the lower pons to complete the process. Okay? Now, the stomach is an organ that's really, I think, underrated as far as digestion goes, because it allows us to do something that we take for granted every day, which is discontinuous feeding, meaning that we can eat a meal and then stop and then go on with our lives. If we didn't have a stomach, we couldn't do that. We would have to constantly eat and generate waste. So this is a big step forward in evolution, right? The stomach has an upper domed portion called the fundus, middle large portion known as the body, and then we have a pylorus, the funnel-shaped end. There is a greater and a lesser curvature. The cardia of the stomach is the region where the esophagus connects to the stomach, and this happens to be near the heart, hence the name. The rugae are the ridges and grooves in the stomach that allow it to stretch. And then you've got smooth muscle in the lining, right? You've got an oblique, a circular, and a longitudinal layer in the stomach, and that's so that it can churn as opposed to simply propel food, right? And then you have in the pylorus the antrum and the pyloric canal and the pyloric sphincter, which is the door out of the stomach into the duodenum. Okay. The stomach mucosa is going to secrete mucus, okay, as well as pepsin, and also secretes hydrochloric acid and a hormone known as gastrin. There are mesenteries around the stomach. Okay, the lesser omentum runs from the underside of the liver to the lesser curvature of the stomach. And the greater omentum is going to hang from the greater curvature, loop over the small intestine, kind of like an apron, and then back to the spleen and transverse colon, where it's connected to a tissue called mesocolon, right? And this is where we store a lot of our body fat. So you can see the lesser omentum here, right? And the greater omentum has been cut away, right? And then here we have everything in place, right? There's the greater omentum flipped up. You can see how it hangs from the transverse colon, right? There is the transverse mesocolon, right? It's still, again, primarily a branch of peritoneum, okay? And then you can see the other mesocolons named for the area of the colon they're attached to, right? Sigmoid and descending mesocolon and so on, right? The stomach is basically to begin the process of protein digestion, to sterilize the food that drops in it from the esophagus, and to continue to churn and mix the bolus with the stomach secretions. Sympathetic input from the thoracic splanchix comes through the celiac plexus, and parasympathetic input comes through the vagus nerve, the longest cranial nerve. The blood supply comes from the celiac trunk through the gastric and the splenic branches and veins of the hepatic portal system, which drain the stomach into the liver, right? You can see here the stomach lining, right? There's 4 tunics. The muscularis and mucosa are modified. There's a muscularis externa. There's 3 layers of smooth muscle in the externa. An inner oblique allows the stomach to churn, mix, move, and physically break down the food, whereas the other 2 layers are for primarily propulsion. Okay, you can see that there are on the surface of the mucosa indentations. These are called gastric pits, and they go down into gastric glands. Okay, and the gastric glands are what secrete the the hydrochloric acid and the pepsinogen, right? As well as the mucus and the enteroendocrine cells are what generate the gastrin. Okay, these cells are meant deep in the pit. They migrate towards the top, and then they die as they're exposed to the harsh environment of the stomach itself, and they become digestive products. Okay, so the constant rebuilding of the stomach lining, along with the protection of the alkaline mucus, is part of what keeps the stomach from digesting itself more rapidly than it otherwise would. Occasionally this breaks down. Occasionally we get an infection from a bacteria called Helicobacter, and that can generate something called a gastric ulcer, and we'll get into that in just a bit. Okay, you can see the gastric pits here, right? The simple columnar epithelia has mucus cells that secrete a double layer alkaline mucus. The surface layer traps bicarbonate-rich fluid under it, and it has gastric pits leading to gastric glands, which generate the gastric juice. And you can see here the different cell populations, right? The mucous neck cells secrete a thin, acidic mucus of unknown function. The parietal and the chief cells are there to produce the hydrochloric acid in the case of the parietal cells and the pepsin in the case of the chief cells. Okay? And what they do is they do their work and then they migrate towards the top and then they end up being shed off into the rest of the lining of the stomach along with the mucus. The enteroendocrines are going to generate things like gastrin. Okay? So those are the different secretions, right? The hydrochloric acid is important because it creates an environment in which the pepsin can function, but it also kills a lot of pathogens. It also aids in hydrolysis reactions, which help to break down a lot of the polymers that make up a lot of the nutrients we consume. Intrinsic factor is critical. It's a glycoprotein that allows us to absorb vitamin B12 in the small intestine. Okay, and then the chief cell secretions, pepsinogen, which is the inactive enzyme, and when it hits the hydrochloric acid, it activates as pepsin, and the lipases, which help to break down some of the lipids. Now, the point about the pepsinogen and its protease activity is an important one, right? All the enzymes that break down protein that are made in the digestive system are made initially in an inactive form that gets activated once it hits the lumen of the pipe, and that's to prevent those enzymes from destroying the pipe itself. Okay? The enteroendocrine cells are going to act as paracrines. They generate serotonin and histamine, as well as somatostatin and gastrin. Okay, gastrin is the big player in determining the amount of churning and the amount of secretion that the stomach does. Okay. Digestive enzymes protect the stomach. Digestive enzymes work in the harsh environment of the stomach, but the mucosal barrier is going to protect it. If we didn't have the mucus, then the acid of the stomach would carve away the mucosa relatively quick, and you would end up with a bleeding wound called an ulcer. Okay, so the bicarbonate-rich mucus prevents that from happening to the stomach lining. There are tight junctions between epithelial cells that keep the stomach juice in the stomach. Right? If we punch a hole in the stomach, you're going to leak the gastric juice into the abdominal pelvic cavity and start digesting your internal organs, and that's danger time. Okay. The rapid replacement of the stomach lining keeps it from carving a hole in itself. Okay, so this also is very important. Okay, however, occasionally what will happen is that on the food we eat, we can encounter a microbe called Helicobacter pylori. Okay, and what Helicobacter does is it latches on to certain types of stomach lining. This is something that you have to be susceptible to in order to get it, because Helicobacter is everywhere. Okay, and what it'll do as it colonizes the stomach lining is it secretes an enzyme called urease, and urease breaks down urea into ammonia and CO2, and the ammonia is a base, and the ammonia neutralizes the stomach acid where the Helicobacter are camped out, and that is also going to allow them to grow and feed off the food that drops into the stomach from the esophagus, and it's going to inflame the lining. And that inflammatory process, which is going to mean histamine release and vasodilators, along with the normal corrosive action of the stomach acid peripheral to where they're camped out, can create a cavitating wound, and that can end up bleeding, and that's a gastric ulcer. And then if it goes to the other side, that's a perforated ulcer, and that's an immediate medical emergency. So why doesn't everybody have ulcers? And the answer is you have to have the right kind of lining for the Helicobacter to latch on and cause all this trouble. So you have to inherit this. We treat this with antibiotics and with proton pump inhibitors that cut down on stomach acid production. You can also exacerbate ulcers through the use of NSAIDs. Okay, NSAIDs is an acronym that stands for non-steroidal anti-inflammatory drugs, and what that can do is thin the alkaline mucus and make it easier for the stomach acid to destroy the stomach lining. Okay, physical digestion in the stomach. We talked about the churning activity of the smooth muscle, denaturation of proteins by hydrochloric acid, and the action of pepsin, right, on the protein in order to help break it into smaller peptides. And then milk protein is acted on by something called renin, which is made by the gastric lining of the stomach in infants. Lingual lipase is going to help break down triglycerides before it's digested, as other proteins are in the stomach. And then the chyme is going to be delivered to the small intestine. Now, things that can cross the stomach lining, anything lipid soluble, right? Alcohol, aspirin, okay, can go right through the stomach lining and into the blood, okay? Certain drugs can do this too. Secretion of intrinsic factor is critical for life, right? Because we need that for B12 absorption, and we need the B12 in order to make blood, because B12 is critical in the production of DNA, which is important in the production of hematopoietic stem cells, okay? So if we don't have intrinsic factor, we have to give you B12 injections so that you can make enough blood to survive. Okay, gastric secretion is regulated by both neural and hormonal mechanisms, okay? There's a cephalic, a gastric, and an intestinal phase, all right? The gastric mucosa produces up to 3 liters of gastric juice daily. Vagus nerve stimulation increases it, and sympathetic stimulation decreases it. Hormonal control is mostly the action of gastrin, okay, which is made by those enteroendocrine cells. That's going to lead to an increase in enzyme and hydrochloric acid secretion. And it's also going to promote more peristalsis, or churning by the stomach. Most small intestine secretions are going to act against gastrin. So if food is in the small intestine is going to produce stuff that's going to inhibit the action of gastrin, because we don't want to keep making stomach acid if the food has already left the area. Okay. The cephalic phase is a reflex is going to be triggered by basically food stimuli, right, in the environment. The gastric phase is about 4 hours, where 2/3 of the gastric juice is kicked out. It's stimulated by stretching of the stomach, peptides in the stomach, low acidity in the stomach, and gastrin. Enteroendocrine G cells are stimulated by caffeine, peptides, rising pH, as well as gastrin. And then the intestinal phase happens when the food is in the small intestine, when it enters the duodenum. Okay, so the gastrin leads to enzyme and hydrochloric acid kick out, and the low pH that's there when there's not food normally inhibits this. Buffering action of the food causes the pH to go up, and that leads to the kick out of gastrin, and that leads to the kick out of hydrochloric acid and pepsin, right, and mucus. Acetylcholine, histamine, and gastrin stimulate parietal cells through second messenger systems, and all three help to maintain hydrochloric acid secretion. Okay, the parietal cells generate the protons that get pumped into the stomach lumen, while potassium goes into the cells to balance the charge across the membrane of the cells. Bicarbonate comes from carbonic acid breakdown and goes into the blood through a chloride bicarbonate antiporter. As a result, the blood that leaves the stomach is more alkaline, and that's known as the alkaline tide coming from the stomach. Chloride from the blood plasma follows the protons and forms the hydrochloric acid inside the stomach. The intestinal phase is where the food enters the duodenum from the stomach. Okay, this is a stimulatory component. Partially digested food enters the small intestine. We have a brief intestinal gastrin release, and then inhibitory effects include the enterogastric reflex and enterogastrone secretion for chyme, falling pH, fats, peptides, and irritating substances once in the duodenum inhibit gastric secretion, right? We don't want to keep making stomach acid if the food is leaving, right? Because that means it would be more likely that we would eat up the stomach lining. Three reflexes are going to act to inhibit vagal nuclei in the medulla of the brainstem and inhibit local reflexes. We activate sympathetic fibers, resulting in tightening of the pyloric sphincter, so no more food goes into the small intestine. And we decrease gastric activity to protect the small intestine from too much acid, let alone the stomach from too much acid. Enterogastrones include secretin, cholecystokinin, and VIP, and all of these are going to inhibit gastric secretion. Okay, cholecystokinin is going to promote the squeezing of the gallbladder and the secretion or the production of digestive enzymes from the pancreas. Secretin is going to promote the production of bicarbonate from the pancreas. Okay, and vasoactive intestinal peptide is going to inhibit gastric secretion and promote absorption. If the small intestine is forced to accept more chyme than it normally would, this leads to dumping syndrome that results in emesis and nausea. This often happens in people that have stomach staple or lap band surgery, okay, reducing the size of the stomach. So you can see here all of the different components that control the action of the stomach and its interaction with the small intestine, right? We have an interplay between the stomach and the small intestine via hormones, right? And then we have an interplay between the stomach and the nervous system through the autonomic nervous system and its communication with the enteric nervous system. So the stomach is going to stretch to accommodate the incoming food, and the pressure stays constant until you get about 1.5 liters in there, and then we have receptive relaxation. You go above 1.5 liters, and then you might end up with emesis, right? You can't keep stuffing food into the stomach too quickly, or else you're going to throw up, and that's to keep the stomach from rupturing, right? The swallowing center of the brainstem takes care of that. Gastric accommodation is a stress relaxation response of smooth muscle, right? Remember that with smooth muscle, it's stretched, it's going to contract, and when it's not stretched, it's going to relax, right? So it runs counter to the stimulus. Peristaltic waves are going to move towards the pylorus at a rate of 3 waves per minute. The electrical rhythm is set by the enteric pacemaker cells, which are linked by gap junctions to the entire muscularis, causing it to contract. Distension in gastrin increases the force of contraction, which is most vigorous near the pylorus. And then the chyme is either delivered in 3 mil spurts to the duodenum, or it's forced backwards into the stomach. As the chyme enters the duodenum, receptors respond to stretch and chemical signals. The enterogastric reflex and the enterogastrones are going to inhibit gastric secretion and duodenal filling, and the carbohydrate-rich chyme is going to move quickly through the duodenum, while fatty chyme takes 6 hours or more, okay? Because there's more there to break down. Vomiting is caused by extreme stretching of the stomach, filling it quicker than it can accommodate, or irritants. These include toxins, alcohol, spicy foods, certain drugs. Why do we respond this way to an irritant? To get rid of the pathogen or the toxin, okay? Get it out. Chemicals and sensory impulses are going to hit the emetic center of the medulla. Emesis just means to throw up, okay? Excessive vomiting can lead to dehydration and electrolyte and acid-base imbalance. So we have to watch this, especially in the very young. Okay, now there's 2 classes of drugs that act here. One are emetics that make you vomit, such as syrup of ipecac, and others are antiemetics that keep that from happening. such as compazine, which they give cancer patients. They get nauseous because their stomach lining is not being adequately replaced, and so it's easy for them to experience irritation and nausea. Okay. All right, we will cut it here. We will finish digestion next week. We have our next exam next week, so that will be due the Sunday next week, right? So we'll finish up GI, and then you guys will have the exam to take care of. And then in lab, we are here. We're doing, I believe, not mistaken, acid base. Oh no, I'm sorry. You're doing the lab exam today, but we're doing acid base in lab next week. Okay, so that's going to be a discussion about the pH of the body, the fluid balance of the body, and the systems that maintain that. All right. Okay. Other than that, I'm done. If we can bump out early unless we have any questions. Do you guys have any questions before we go ahead and exit?
Yeah, so lab next, are we gonna have over the urinary?
Okay. We had our lab over the urinary last week.
Right.
Right. So lab exam, practical, is going to be veins, respiration, and urinary.
Okay.
Yeah. And then the next week's lab is going to be acid-base balance. Anybody have any other questions? We cool? All right. We'll bump out. See you guys next weekend.